Tinea corporis, another shape of dermatophytosis that involve skin of body or a ringworm of body. Some dermatophytes that explain some information about them, like as Trichophyton rubrum, Trichophyton mentagrophytis, or Trichophyton verrucosum, for example, are some species of dermatophyte that lead to this infection. Usually in Tinea corporis, in ringworm of skin, usually you see annular lesion, a ring form of region, annular region. In this picture, you see erythema, redness, inflammation, and if there is hair, may you see missing the hair and losing the hair. But in a skin, usually a ring form of lesion is important for clinical sign and clinical diagnosis. You must attention to a ring form of lesion with inflammation, with redness. The lesion have margin, sharp margin between normal skin and the lesion. It is important, and the lesion usually spread and change to large lesion compared to before lesion. This is a shape of ringworm or annular form of lesion. A ringworm or ring form of lesion. You can see the margin of lesion. You can see and differ normal skin from the annular region. Sometimes you have single lesion, but sometimes may the lesion spread to another site of body because the patient have itch, and with itching the spore, the contamination can transfer from lesion region to normal skin. In this picture, you can see multiple lesion of dermatophyte. For diagnosis of Tinea corporis, you must attention to a ring form of lesion. Yes, redness, scaly, and alopecia that may add to this lesion, but the ring form of lesion is very important. There are some differential diagnosis of skin disease. Do you know differential diagnosis? What mean?
Sign that make a disease different from other diseases.
When we have some similar lesion, we must different this from the other. In this lesion, in dermatophytosis, we have some skin disease that may was similar to dermatophytosis. Therefore, we must detect which of them. For this infection, for dermatophytosis, for differential diagnosis, you must suspect with clinical sign and refer the patient to laboratory and take the answer and report and decide for it. Like as tinea capitis that I explained you before. There are some differential diagnosis infection, differential skin disease that may you mistake with dermatophytosis, like as eczema, like as psoriasis or psoriasis, psoriasis, eczema, and there are many skin diseases that may you suspect to that infection, and therefore for a good diagnosis you must refer the patient to laboratory. For number and rate of the infection, tinea corporis is medium number of patients in compared to tinea pedis, in compared to tinea angium. Now, tinea pedis show a high number of frequency, number of patients. Tinea cruris show high number of frequency, high number of patients. But in compare, tinea corporis is low in about tinea cruris or tinea pedis. Usually involve all people, man and woman, children and adult person. And for a good diagnosis, you must have a correct report from laboratory, because the treatment of eczema, psoriasis is different with treatment of tinea corporis, dermatophytosis. Dermatophytosis need antifungal, but for treatment of eczema, you need anti, you need corticosteroid for control the hypersensitivity of reaction that you see in the skin. If if you have incorrect diagnosis, the treatment of disease made to problem. Until in tinea corporis, in dermatophytosis, you must use antifungal, and if in mistake you use corticosteroid, the infection change to reaction to high reaction to acute reaction. Therefore, for a good diagnosis, for a good treatment, you need correct diagnosis with laboratory report. Another shape of infection is tinea angium. I think it is better I explain it at the end, because it needs more explain and more description. Tinea pedis, another type of ringworm. It is a common infection in adult person with a high number in male, more than female in number. Dermatophyte of foot in pedal area, and another name is athlete foot, because athletic person and sportsman use in long term of shoe, and this condition uh, prepare the factor for infection. If there is the agent, there is a fungi. In Tina pedis, we have usually Trichophyton rubrum, Lycus tina corporis, Tina mentagrophytis, war interdigital, and the other dermatophyte like as epidermophyton follicosum. Epidermophyton follicosum that has human source cannot invade hair. You cannot find lesion by this dermatophyte in head. In Tinopedis, may you have many clinical aspects, clinical manifest from chronic lesion, chronic reaction to acute reaction based on the species of dermatophyte. From a scale from a scaly lesion to acute reaction like as vesicle and pustule. Do you know what is vesicle and pustule? This is some word that dermatology you must understand and you must know. Uh, Vesicle or vesicle and pustule. Somebody can explain what is vesicle, what is pustule, what is bull. This reaction you may find in dermatophytosis, especially in Tina pedis. You must search and find the answer. What is vesicle skin in a skin? What is pustule and what is bull reaction? You can find this vesicle pustule in foot, in pedal area. Usually, dermatophytosis of foot, dermatophytosis in Tina pedis start from interdigital space. Interdigital space. That name of interdigital space in foot is toe web. Toe web means interdigital space in foot. Toe web. Toe mean finger. Toe mean finger. Toe web, the space between the finger. Therefore, toe web. Usually, dermatophytosis is Tina pedis start lesion from toe web, especially the fourth space, fourth toe web, and grows from here to sole. Sole means plantar of foot, plantar. Dorsum of foot, finger and, no, and nail. This infection can involve not only a skin but also the nail and lead to tenoangium. Sometimes you have, or usually you have tenoangium with tenopedis, and you must uh, prepare, we must decide for treatment, all of them. In clinical manifestation, you may have chronic lesion, chronic scaly, and subacute, sometimes acute. Acute means vesicular, pustular, bular, symptomatic, pustular symptoms. Sometimes there is only contamination without any clinical sign that we say asymptomatic colonization, asymptomatic contamination of food. Okay, in some picture you have a scaly lesion behind the toe. The infection without treatment can grow, can spread to the other part of skin. You can see the margin of lesion. The margin of lesion usually involve one foot, sometimes both. In this picture, you can see chronic lesion and destroy the keratin layer of skin. In this patient, you have seen uh, that fit show the infection and a scaly lesion, scaly. In this patient, the infection involve skin and nail, skin and nail in both feet. In toe web space, you can see the lesion. If you generally, if you find lesion, skin lesion, scaly lesion in foot, you must refer the patient to laboratory. Usually, generally, and you must wait for the report of laboratory for decide the treatment. And in that patient, you can see the infection in sole. Sole means plantar area of foot. Palm and plantar. Palm in hand, plantar in foot.
Postula?
But
Postula?
this patient, sole.
What's it called? Postula?
What shall I? Pustule. In this picture, you have pustule. We haven't any pustule here.
So what's called here?
Which kind?
What's called here?
I don't understand.
What's called here?
What kind?
Yeah.
Scaly. In the sense of scaly. In this erythemato, we have multi aspect, multi clinical from scaly with chronic until to pustular, based on the source of infection, based on the species of dermatophyte. You have see some vesicular lesion in this, but the vesicle breakdown and out the serum, out the water. Okay. Another type of infection is tinea cruris, the dermatophytosis of groin. Groin means skin of genital area. Groin. A skin of genital area, a special form of tinea corporis because limit to genital area skin. Usually, the etiologic dermatophyte is Epidermophyton felucosum. You can find this dermatophyte from media, isolate from media in laboratory. Another species, Trichophyton grophitis, Trichophyton rubrum. Usually you find this lesion in man in compared to women. Usually the lesion spread uh, to buttock area and down to thigh or to semi-thigh. In this area, when the etiologic agent is Trichophyton mentagrophitis, you must wait for or estimate the speed of infection to buttock area. But epidermophyton filicosum and rubrum limit to skin around the genital area, and usually you haven't any lesion in man in scrotum, in testis. In this picture, you can see the lesion that spread to body, to abdomen area or to buttock. The lesion may show scaly in chronic form and inflammatory reaction in acute form. Like as these like as the other dermatophytosis, you must refer the patient to laboratory. In laboratory, uh, in infection that involve skin, we must prepare the sample. In this condition, intina capitis, intina pedis, intina corporis, intina cruris, we must prepare the sample. What is sample? Skin scrap, not hair. Skin scrap usually is sample that you must prepare in laboratory and examine it with microscope with KOH preparation. KOH solution is a good solution that sharp fungal element and prepare the slide, and you can find fungal element under microscope. Uh, Skin scrap need for preparation of provide and preparation the sample and examine with microscopic examination and culture. Usually for the diagnosis of mycotic infection, we have two way. One, or first, microscopic examination. Second, culture. Culture for isolate the fungi, the species, the genus of fungi, and detect it. And it is very important sometimes, culture method. Tenobarbi, another infection of dermatophytosis that uh, that involve skin of face both in man and women, usually and more than in man, especially in what? Yes. Face usually when we face forehead, cheek, and chin and neck in Tina Barbie may involve the mustache. In next, I explain. We have two types of Tina Barbie. First, superficial, superficial lesion. Superficial lesion mean involve the surface of skin of face without folliculitis. In deep or second type of Tina Barbie, you can see folliculitis that involve the mustache and lead to sometimes release the hair, miss the hair, and sometimes produce abscess, deep abscess in follicular type, in deep type of involvement of hair, mustache, especially in man. The lesion, the reaction may change, may differ from chronic type, chronic, like as this picture, you have only some release of hair, missing the hair, and scaly, it is chronic. Or inflammatory form, acute form, redness and inflammation and folliculitis that spread. Or sometimes in second type, in deep type of Tina Barbie, you may find and see uh, deep abscess, deep abscess when the agent is trichophyton verrucosome, you can usually find deep type of Tina Barbie. Tinomanum, another type of dermatophytosis that involve five finger, palm, and dorsum of the hand, interdigital space, and sometimes fingernail. In foot, we say toenail. In hand, we say fingernail. In foot, we say toe, but in hand, we say finger. Interdigital space, in foot, toe, web. Okay, in Tina manum, the clinical sign based on the species of dermatophyte change from chronic type with some scaling to vesicular, pustular, and inflammatory reaction or redness and vesicle. Uh, the frequency of infection in compared to tinopedis is low because the person, the human, usually wash the hand and there isn't enough time for colonization of dermatophyte in a space, in interdigital space. But may you less wash your water, especially toe web space. Uh, for good diagnosis in all of them, you must have laboratory report. Okay, come back to trichophyton, come back to tinaangium. Tinaangium that tinaangium that today is very important disorder is nail disorder and the need to a good and correct diagnosis, not only in clinical but also in laboratory. And the diagnosis is very difficult also in laboratory method and need to expert man that have experimental uh, information for diagnosis of this infection, because there are many disorders that involve the nail, from a limitation, malnutrition, vitamin deficiency to cancer, from malnutrition to cancer lesion, kidney disease, thyroid disease, metabolic disease, diabetes. Many disorders lead to uh, disease in nail. One of them is fungi. If dermatophyte involve the nail, we have tina angium. If in addition to dermatophyte, the other fungi, yeast, and the other mycelial form, the other mold affect the nail, tissue nail, this lead to onychomycosis. In clinical central uh, in laboratory, we must detect, is there any onychomycosis occurred or not at first. At first, a physician must can tell this disorder is onychomycosis or not. It is very important because the treatment is different. If you have deficiency of vitamin or mineral, treatment is administration multimineral. But if you have tina or angium, you must admit antifungal drug. It need to correct diagnosis. In tina angium and dermatophytosis of nail, we have usually the infection in toenail, in foot. After that, in fingernail. Usually, one nail infect, one nail usually, but sometimes multiple lesion you can find in all of finger, on of toenail. Usually in toenail, sometimes in fingernail. When you have a patient that nail affected by dermatophyte, at first you see change the color of nail. The nail color change to white, to yellow color. After that, the nail show hypertrophy, means thickness. Nail show thickness. And after that, the thickness yellow or brown nail start to break down and destroyed. You can see change the color in here. You can see hypertrophy or thickness in this patient, change the color. Usually, tenoangium start the edge of nail, proximal nail. Usually, usually start from here. Sometimes, sometimes start from the proximal. Sometimes may start from the medial or lateral. And it is not important for diagnosis the type of onychomycosis or not, but we must consider one. We must consider it. This patient must refer to laboratory. In laboratory, we must prepare the sample with a scalpel. We must scrap the nail, and use a lamp and pour the sample on the surface of lamp. First, we must culture this sample to media. In nail, we must use two media. One media is saburo with chloramphenicol. Saburo with chloramphenicol. Second media, saburo with chloramphenicol and cycloheximide. Two media we need. SC, SCC. SCC for isolate the dermatophyte, because dermatophyte resistant to cycloheximide. Chloramphenicol used for prevention the growth of bacteria, but cycloheximide prevention the growth of some fungi, except dermatophyte and some systemic pathogen fungi. SCC, saburo with chloramphenicol and cycloheximide is a choice and selective media for isolation the dermatophyte. Therefore, for isolation the fungal element in diagnosis of tinea angium, we must use two media, SC, SCC, because may the etiologic agent, may the fungal agent is not dermatophyte, is a candida, is a yeast, is the other mold fungi. Okay, in sorry, quite please, sorry. In microscopic examination, after you prepare the sample with KOH smear, in skin and nail, you must pay attention to mycelium with arteroconidia. At first, in introduction, I told you some mycelium produce arteroconidia, breakdown from septum. Dermatophyte in pathogenic condition produce arteroconidia. I will uh, I will show the arteroconidia in laboratory. Sorry, ما بریم اصل فلاشو بیاریم،
چی؟
اون فایل های اصلی اوریجینال نیاوردیم. No. Yes, yes. Medical malpractice.
بعد از کلاس کدوم لکسن فرستاد؟ کوتانیوس یا سابکوتانیوس یا سیستمیک؟ شما سه تا فرستادی.
آره سوپرفیشیال هم فرستادم ها. میخوای کوتانوس رو بذاری؟ کوتانوس الان فکر کنم موقعشه دیگه نه؟
چی؟
میگم الان موقعشه دیگه نه؟
آره.
بذار اینم بگم براشون. Is this Tina capitis or not?